Welcome to the Explainer. Today, we're diving deep into the world of seizures and epilepsy. We're going to unravel what exactly happens during one of the brain's electrical storms. And then we'll follow that path from a single event all the way to a diagnosis and a plan. So let's get right into it.
So what do we even mean by an electrical storm in the brain? Well, you can think of it like a sudden, pretty intense short circuit in the brain's wiring. For just a moment, all the normal, orderly electrical activity gets completely disrupted.
All right, so here's the official definition. A seizure is a transient event, and that word is key. It means it's temporary. It's caused by this abnormal, way over-the-top electrical activity. Basically, a whole bunch of brain cells start firing off all at once in a chaotic burst, and that's what interrupts normal brain function.
Okay, this is a super important distinction to make. A seizure is the electrical misfire that's happening inside the brain. A convulsion, on the other hand, is what we might see on the outside, the muscle stiffening or jerking movements. And here's the thing, not all seizures lead to convulsions. You can absolutely have a seizure without any of those outward signs.
Right, so let's start breaking this down. To really understand what's going on, neurologists have to classify the seizure. And the very first, most important question they ask is, where exactly in the brain did this whole thing start?
And that question leads us to this first major fork in the road. You've got focal onset seizures, which kick off in one specific area on one side of the brain. And then you have generalized onset seizures, where that electrical storm basically ignites and spreads across both sides of the brain almost at the same time.
Now, if we're talking about a focal seizure, the next question is all about awareness. Was the person conscious of what was happening? If their awareness is totally normal, we call it a focal seizure with intact awareness. But if their consciousness seems off, maybe they have a blank stare, or they're doing repetitive things like smacking their lips, that's a focal seizure with impaired awareness.
Over on the generalized side, things can look really different depending on the type. You've got absence seizures, which might just look like a kid zoning out for a few seconds. Then there's the one most people picture, the tonic-clonic seizure with the stiffening and then jerking phases. Atonic seizures are different again. They cause a sudden loss of muscle control, leading to a fall. And myoclonic seizures are these super quick, lightning-fast muscle jerks.
So, let's imagine someone has one of these events. Now what? How do you get from a single, one-off seizure to the diagnosis of a long-term condition?
Well, believe it or not, the key to diagnosing epilepsy often comes down to this number right here, the number 2. Let's talk about why.
And here's why that number is so important. Just having one seizure does not automatically mean a person has epilepsy. See, epilepsy is a condition where your brain has an enduring tendency to have seizures. So to get that diagnosis, you typically need to have at least 2 unprovoked seizures, meaning they weren't caused by something temporary like a high fever, and they have to happen more than 24 hours apart.
You know, this really gets at one of the biggest challenges for doctors, telling the difference between a seizure and something like a common faint. They have to play detective, looking for clues. Fainting usually has a clear trigger, like pain or fear, and you bounce back really fast. But a big seizure often has no trigger at all, and the person can feel out of it for minutes or even hours afterward.
Getting the diagnosis of epilepsy is really just the start. Epilepsy isn't just one thing, it's an umbrella term for a whole bunch of different syndromes, and each one has its own story, its own features, and its own best path for treatment.
For example, let's look at juvenile myoclonic epilepsy, or JME. This one almost always shows up during the teenage years, and its hallmark, its classic sign, is those quick muscle jerks, especially right when you wake up in the morning. It even has its own signature pattern on a brainwave test.
Or take another common one, mesial temporal lobe epilepsy. This is actually the most frequent type of focal epilepsy. It's often tied to a tiny bit of scar tissue deep in the brain. Now, why is it so important to identify this specific syndrome? Well, because it often doesn't respond well to medication, which means that brain surgery can actually be a really powerful, sometimes even curative, option.
The main tool for figuring all of this out is the EEG, which is basically a recording of the brain's electrical chatter. And different epilepsy syndromes have these unique electrical signatures. An absence seizure has this classic, rhythmic spike and wave pattern. Infantile spasms have this really chaotic, messy-looking pattern called hypsarrhythmia. It's almost like learning to read the brain's own secret language.
Okay, so a diagnosis is made. A syndrome is identified. What's next? Well, now begins the really important part, managing the condition so that a person can live the fullest life possible.
You know, the goals for managing epilepsy today are so much bigger than they used to be. Of course, stopping seizures is goal number one. But just as important is focusing on the whole person. We're talking about minimizing side effects from treatment, dealing with any other related health issues, and, most importantly, making sure quality of life is as good as it can possibly be. It's a huge shift from the old days of just counting seizures.
And this is exactly where all that careful work of classifying the seizure type really pays off. You don't just pick any random medication. The drug that works best for a typical absence seizure, for example, is completely different from the best drug for a focal seizure. It's truly about picking the right tool for that specific job.
This quote just nails it. This is the whole philosophy of modern epilepsy treatment in a nutshell. It's all about personalizing the care, matching the right drug to the right kind of seizure in the right person. That one-size-fits-all approach is long gone.
So that leaves us with this final thought. As our ability to understand and map the brain's incredible electrical network gets better and better, what's on the horizon? From super precise neurosurgery to therapies that target a person's specific genes, the future for managing these electrical storms in the brain is looking brighter than ever before.